6 minutes is not sufficient. In fact, 6 hours is not sufficient. In fact, 6 days is also not sufficient to talk about osteoarthritis. It is such a vast subject. And keeping that in mind, today we are talking osteoarthritis on classification, investigation, and imaging in between the ongoing challenges that we all face in the world and we are facing. A lot of things are going to be a part of our therapy, the part of our investigation, the part of our treatment protocol that we can talk about. And with this in mind, I hope and everybody is immune or at least vaccinated, and we take it forward. Osteoarthritis, coming to classification, I think Yogesh, Dilip, and Raja has given a beautiful narration on how, where, what, and a lot of things have been going to be in and out of, what shall I say, is similarity will be there in the slides or probably the subject, some of them. So hence, I would definitely take a key point here to make sure that we will look at the symptoms and how do we classify and how do we take it forward. Keeping that in mind, I mean, obviously we all know that we have different variety of deformities coming in. So we need to make sure we don't get there. That is the biggest issue. That is the biggest criteria for all of us to make sure. Keep it early, pick it up early so that we can, avoid these challenges. In the classification, I think briefly mentioned earlier on by Dr. Dilip, we have pathological and radiologically we can classify. Now, coming to pathologically, we can talk about primary and also secondary. So, points have been touched upon by all the three speakers. I'll just run across a few things what can be a part of our ongoing issues that is going to be majorly affecting us, because that is a key factor for us. We need to treat the condition where we are coming from, not just the symptom of pain. Yeah, pain relief is the main thing, agreed. And inflammation control is the biggest thing, but we need to be very clear as to where and how we can talk about it. So the time is running out, and obviously I'm going to be running through this entire number of slides. While grading, we have different variety of deformity coming in because of the degeneration happening in a different region. So let us classify from 0 to 1 kind of a grade in radiological docking. The best classification has been taken, and there are a lot of classifications. I will not run through that, but one example to talk about is the KL, or probably the Kelvin-Lawrence. We all know that grade 1 to grade, or probably you can talk it as grade 0, which could be the normal one. So there are 5 grades of arthritis, or the knee grading can be done. And that definitely makes a point for us to take it forward in terms of our treatment and what stage they come in, and how we can treat further and also predict the kind of treatment that we can talk about it. Coming to the hematology or the blood investigations, there are quite a few things that we need to talk about it. So let me talk starting with hematology and serology. Now, as a patient comes in, clinical examination. In fact, the biggest thing is history. History and clinical examination gives us almost 90 to 95% of our diagnosis, they say. But today, we are not just talking about just that. You and I know that. Today, we are practicing legal medicine. So you need to substantiate and make sure that patient gets the right kind of systematic way of approach so that he or she gets the better pain relief and quality of life at whatever age they come in from. Mind you, osteoarthritis is coming in very early now, not just old age. It is not a symptom of old age anymore. So that's the biggest challenge. Depending on the kind of patient, either a male or a female, there are certain tests that we need to include. These are, by and large, we need to include in our investigations. Very, very important, because this plays a very important role in differentiating the secondary causes and the treatment protocol that can be taken forward. So keeping that in mind, the biggest thing, Dr. Dilip mentioned about the softening of the bone. Yeah, osteoporosis is the biggest thing. And there's a spelling mistake here. I'm sorry about that. It's biomarkers. Pardon me for that. And then we talk about the synovial fluid. It's a big effusion comes into the joint, and then what happens? We aspirate and throw it in the bin. Mind you, it's so important for us to take it get a serum, synovial fluid analysis made, examination made microscopically, physically, and we need to look at the culture and sensitivity. If there's an infection, if there's a crystal arthropathy coming in, a lot of things are there. Very, very important factors that need to be kept in mind. So these are some pointers that we keep in the radiological investigations. What do we talk about? I think it's been done already, but the modalities are very, very good ones. The basic X-ray, right from the time of Roentgen's invention. Today we talk about get a standing AP. Classically, every radiology technician makes the patient lie on the table and get the AP lateral. It's fine if the patient is not able to or differently able, or if there is any issues. But by and large, we need to get this because we need to see a lot of alignment from the hip joint, pelvis, in fact, pelvis to down the knee to ankle. So very, very important. And then to talk about, we also have, in the tier 1 and tier 2 cities where they may not have an access for a lot of higher investigations, skyline makes a big, big importance. Scanogram again is limited to the digital X-ray, units throughout the country. So that is one. Ultrasonography is one of the biggest musculoskeletal, radio diagnosis tool that has come in the recent past. In fact, orthopedic surgeons are also getting a training done there. Sports medicine, people are getting trained under that. And then it's a very important tool. We don't need to get really worked up. And if you're not, you can refer them, but you need to have a good hand of ultrasonography. CT scan is a major important thing. MRI, no doubt about it. Yes, bone density makes a big, big impact. Scanogram, we need to see the alignment of the bone, basically, so that we can plan our treatment accordingly. Then comes our, the grading comes into picture, different pictures, different stages. Is it mono or unicondyle or bicondyle, and tri-compartmental? All those challenges. We've seen this in time and again. We go on and on these things. So when you follow up a patient, you could see the progress happening. You could have prevented, or probably, kind of thing. That is one of the biggest things that we talk about. Now, coming to ultrasonography, you need to have orientation. Where is the probe? How you are interpreting each and every structure that we're going to see and scan it. So keeping that in mind, what are we talking about? There could be a probe which is coming in, and then you're screening from anterior posteriorly. How do we see the structure? That is very important for us. This is not the time to class to give a detail, but this is just to give you a bird's eye view of investigation. When you do it on the medial side, you could see an image differently again. That has to be interpreted the way you can scan it. Very important. And again, mind you, it is not just radiological classification. We also have ultrasonological classification of the osteoarthritis in the knee joint. Very important. I will not take the time. Now, CT scan, very important, because there are a lot of other structures which may not be picked up in the X-ray. We need to rule out and make sure that is happening. And then see, that is the biggest challenge now. Osteochondritis happening here, and chondromatosis happening, and so many issues the joint may have. We may miss out in the radiology, the common simple X-ray. So that is important for us. But that doesn't end the show there, because we need to see the soft tissues as well. And then how is the damage happening in the soft tissues? That gives us the clarity. The biggest tool that each of us can think about is MRI. So very important for us. The MRI grading of the osteoarthritis is another classification coming in. I don't want to confuse you with too many classifications, but yes, MRI makes a big thing. And again, MRI can be plain MRI. Also, we could have with contrast. Here we talk about a proton density weighted, or that is actually a T1 or T2 images can be done. And if necessary, in the past, we did what is called an arthrogram, where we used to inject a dye. Today, it's history. We don't even do that. So today, we can do that with a simple dye injected into your vein, and then everything is taken care. So very, very important for us, because the treatment lies in a massive way in the kind of staging. So with this, I give my short bird's eye view of investigation, classification, and imaging in osteoarthritis. Thank you.